This patient was referred to me for endodontic treatment of tooth number 15. You can see large recurrent decay right there. That's the composite restoration. And look at these roots, the curvature of these roots, and look how long they are. These roots were 25 millimeter long, and look at the curvature of them. So we went ahead and started and completed the endodontic treatment in one appointment. And of course, number one thing that we did, remove the decay, rebuilt the missing walls there, and take a look. Take a look at the curvature of these canals. 25 millimeter long on tooth number 15, upper left second molar, MB1, MB2, distal buccal, and palatal. Everything went great. As you can see, we temporized the tooth and referred the patient back to his dentist for the permanent restoration. Tooth number 15 is the upper left second molar. And as I said, these were, as you can see, quite a curvature on them. And we had to use 25 millimeter files on this second molar on the upper left side. Tough to get to, but as you can see, everything went great. This is another angulation of the tooth number 15, and you can see MB1, MB2, and look at that beautiful curvature. Almost a 90-degree curvature here. And distal buccal and palatal. This patient was referred to me for endodontic treatment of tooth number 3. He presented with a phoenix abscess. Periapical lucency here and here, to some degree there. That's one angulation. That's another angulation. You can see the periapical lucency associated with the palatal root there. Periapical lucency here. Crown. As I said, the patient had a facial swelling, phoenix abscess. We went ahead and placed him on antibiotics and brought him back. Yesterday, facial swelling was gone. Now, the facial swelling was gone, but now he had a couple of sinus tracts. So let me show you all of that. All right, so that's the facial swelling, as you can see. Look at the left side, look at the right side. This is what we call a phoenix abscess. And I don't like to IND these. I'll put the patient on antibiotics. I usually put them on 2 antibiotics, amoxicillin and metronidazole together, and patient goes home with no incision and drainage and stitches and all of that discomfort and everything else that comes along with it. Patient leaves with a prescription, and patient came back yesterday. Facial swelling was gone completely. Let me show you now the sinus tracts now. So that's the tooth here. You can see there's a sinus tract here on the marginal gingiva, and there's another one up there, but no intraoral or extraoral swelling. The antibiotics, the 2 antibiotics that I put them on, worked perfectly. Went ahead and talked about his options with him: root canal with guarded prognosis or extraction. And patient wanted to try to save the tooth, and that's what we did. We went through the crown and we did this root canal in one appointment. And take a look. And here's the post-op. MB1, MB2, distal buccal and palatal. As you can see, everything went beautifully. Let me show you a different angulation. You can see that. Everything went great. That's another angulation. So we went ahead and temporize the tooth and refer the patient back to his dentist for the permanent restoration. And that's another angulation. Excellent. This patient was referred to me for endodontic retreatment of teeth number 2 and number 3. According to the patient, both of these root canals were done by a traveling endodontist approximately 2 years ago. Now, both of these teeth hurt, and he was referred to me for examination, evaluation, and endodontic retreatment of both teeth. So, to look at tooth number 3, crown here, of course, previous root canal, small periapical lucency there. Look at tooth number 2, crown, previous root canal, periapical lucency. That's a post right there. Both teeth tender to percussion and palpation. Probings were 2 to 5, 6 millimeters. Patient admits that there is a food pocket right in between the two teeth. Right here, you can see on this angulation. That's a food pocket. So that's perio. Look at the bone level in the mesial of tooth number 3, and look at the bone level in the distal of tooth number 3 and mesial tooth number 2. So that's a food pocket. That's perio. And this needs to be addressed. As you can see, it's already consumed almost half of the distal buccal root and half of the mesial buccal root of tooth number 2. Anyways, if you don't tell these things to the patient, who's gonna tell him? Because patient's general dentist never told him about this. This needs to be addressed. Someone needs to take care of this. Someone needs to take initiative. So, and also you got to tell the patient, because the patient is under the impression that they come to see you for you to redo the root canal. They could assume that the root canal will also take care of this, because patients don't know. Patient didn't go to medical school, to dental school. They don't know this stuff. All right, so someone needs to take the ball rolling on this, and it was me. Basically, that's what I did, because patient had no idea. The general dentist never told the patient about this, even though the patient claims that he complained multiple times to his dentist about this problem. So we talked about options with the patient redoing both of these root canals, and then patient will have his dentist refer him to a periodontist. A periodontist should be able to take care of this, get rid of this food pocket here. It's called a pocket reduction surgery, and that is done routinely by periodontists. So a periodontist can get rid of that pocket there. So patient wanted to try to save both teeth, and that's what we did yesterday. We went ahead and redid this root canal for him, went through the crown and redid the root canal on number 3, and he'll come back for us to work on tooth number 2. So let me show you tooth number 3, and this is the post-op of tooth number 3. I troughed for an MB2. There was no MB2. So on this angulation, you can see the large periapical lucency that are associated with tooth number 2. This is, I think this is just all sealer from when the dentist did the root canal in tooth number 2. I think that looks like sealer. Anyway, so let me show you a good x-ray of the retreat of tooth number 3. Right here, as you can see, I did trough for an MB2, and I trough really well just to make sure that I'm not missing it. I'm not missing an MB2. It's rare that these teeth don't have an MB2, and in this case, this tooth did not have an MB2. All right, so next time I'm going to do the same thing with tooth number 2. You can see a periapical lucency here, prefab metal post there. So I'm gonna trough here, looking for an MB2. Of course, I'm gonna redo the root canal like what I did here. I redid the root canal. This was not a selective retreatment. We treated the entire tooth. And this is just another angulation of tooth number 3. You can see that I troughed and just could not find an MB2. And the other thing that you can see here is that you can see my gutta percha is centered in the mesial-buccal root. So that's another indication that there was actually no MB2 present. All right, so as you can see, everything went great. We temporized the tooth and refer the patient back to his dentist. I don't know when he's coming back for tooth number 2, but that's the next tooth we need to retreat.